Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I've got Mark and Drew here. Lucas off for the week, so I hope he's enjoying himself. Let's start off, guys. Just a quick little icebreaker for both of you this time. So I'll start with Drew. Drew, where is favorite family summer vacation spot?
I think it's got to be the beach. Some of that comes from my wife, who says it's not a vacation unless we're at the beach, but almost any beach with some sunshine and a book and a drink in my hand, and it's going to be a good time.
Okay. Spoken like a man that doesn't have little kids anymore. This is
Yeah, they've kind of got out of the I have to follow them around everywhere stage. So we get to have fun. I get to throw football,
sunscreen
play games with
everywhere,
them. That's also fun.
carrying all the things. Yeah. All right, Mark, how about you?
Um, uh, it's going to be the beach as well. We used to go to Sunset Beach every year as a family. It's the first beach in North Carolina coming up from South Carolina. Pretty family-oriented beach. And so me and my extended family would always go there every summer. We had like a specific week that we would go. It was like a planned and consistent thing and expectation, and that was
Yeah.
always a good time.
Very cool. I think it sounded like a plug for anybody listening that wants to give it some advertisements here. Going Sunset Beach sounds like a place.
There you go.
As long as they have putt, right? I mean, I think that's just a key feature there. All right. So what we want to talk over today is going to be modalities. So lots of different things and directions that we can go on here, but really I'm looking from you guys, successful clinicians in your own right. You've trained and worked with a lot of new grads, a lot of experienced clinicians as well too. We've also talked about there's going to be a pendulum that swings back and forth. Of we know that there was a time when our starter of Breakthrough, Jeff Hathaway, would probably admit that everybody was doing modalities when they came into PT, and then we've kind of had some different shifts in that time period, and really we kind of just want to discuss a little bit of what you guys' perspective is. So, Drew, why don't you just start us off? Is there a time for modalities?
I think there definitely is. Like you said, there used to be a lot of probably overuse of modalities in the field of PT. And then it was probably around the time that I started a PT, now like 14 years ago, so it's been a while. It started really shifting back to the point where there's some clinics as they're starting up, they like don't hardly have any modality stuff, which is fine. But I do think there is a place for it. If you're looking for long-term change, that's probably not where it's going to be. But I definitely think there's a time and place when they can be useful for that short-term change. Um, I was kind of shocked at one point when we were talking about chronic pain in Adrian Low course, and he said, "Oh yeah, he uses TENS all the time. In fact, he calls it his Pain Blaster 3000 or something like that." And his big thing was everybody who has chronic pain at one point had fairly acute pain. And if you can start decreasing some of their pain and decreasing their fears and anxiety around it, even if you're using some modalities, your likelihood of having some long-term chronic pain are going to go down. And those are really good ways to use it, I believe, when they're having a fair amount of pain and they maybe can't do as much or aren't as functional. So you get them less pain, you get them moving, and you really encourage the things that are going to help long term.
Yeah, I like it. So deal with any barrier that's keeping people from moving, and sounds like TENS in the chronic pain world see some benefit with that. Absolutely. All right, what you think, Mark?
Yeah, I think there definitely is a place. It's a means to an end. So, like Drew said, it's something relatively short term. It's input into the nervous system, whether that be e-stim, whether that be uh, ice or heat. Like you're getting some input into the nervous system, and the goal is then to say, I'm doing this so that I can do this active thing with less pain or more comfort. It's almost no different to why we use manual therapy. It's a means to an end. I need them to be able to move better with less pain, or more quantity, whatever it may be. And then when you think about like the alternatives, okay, what's worse for the patient? Taking a bunch of NSAIDs, which we know a lot of the side effects and a lot of the newer stuff coming out about NSAIDs, or maybe I put TINs on them while they're moving. I find that much more conducive to the patient. They're able to move with less pain, and now they're not having those negative alternatives from some sort of medication injection or otherwise.
Yeah, I like that perspective as well too. I know sometimes it's nice as a younger clinician to hear, and it seems like I think you guys would probably agree. Most of the newer grads coming out of school have kind of gotten a little close to the do not use modalities for anything world, and I'm not hating on that. I'm not saying that shouldn't be a direction that some want to go, but I feel like there's also some benefit in our younger clinicians hearing you can use a modality, especially if your if your purpose is good. And to your point, Mark, it's a pretty low risk intervention, especially if you're using it with the gain of, hey, I want you to be able to move. And I can think of times that, I just held off on using TENS, even though a patient was asking for it, because I kept trying to convince them, like, this is not going to help you. This is not going to help you. And then time the third visit came around, they kept asking for it. I finally did it. Um, and then went about, after it, working through some strengthening, and they did significantly better that session. It was kind of just that quick reminder of, all right, patient buy-in, patient value, and patient belief is important on this end as well too, right? So
Yeah.
Yeah, and I'll also do it while they're doing exercise. Like if your goal is to have them do exercise, put some IFC or something on them, make them more comfortable and then get after the exercise. That way it's passive and active at the same time. Like you're still doing what you need to do to accomplish the goal that you need.
Yeah. I've I've also done it in a similar way, maybe not always while they're moving, but if they come in and they're a little bit flared up, maybe they had a stressful day at work, they're kind of that nociplastic patient, some central sensitization. You know what? Hey, let's go to this room. Let's turn the lights down a bit. Let's get some heat and some IFC on. Let's see how you're feeling in 10 minutes. Oh, that's feeling a little bit better. Great. Let's start moving now. And those are the types of, I think, the ways that are most useful for me. Not to say I haven't used it. Someone gets a little flared up during a session. All right, we're going to calm it down. This will give you some short term relief so it's not maybe so sore. Afterwards, you push them, maybe underestimate irritability, which happens at times, and they're a little flared up. Well, do something nice for them at the end and get them to be less fearful of movement, because if they leave and it's more flared up and it stays that way, they're probably going to end up potentially to have a little bit more fear of doing something like that again.
I can, there's a couple things I can think of. One, there's one ortho that has sent me a lot of patients with knee surgeries, especially with ACL post-op. And, within his protocol, the one thing that he really pushed on, and he kind of let me do most anything else, was just that each patient was going to go home with an E-stim unit and essentially TENS for the first couple days, but then he really wanted neuromuscular E-stim on that quad as much as possible in the first week or two. And, I think everybody's going to have some differentiating thoughts on it, but when I compared it with other patients, I mean, it made a big difference. And I was just interested how that same ortho would also send me rotator cuff repairs, and every single one of them, he would send home TENS that he would have them keep on for the first 3 days after surgery. And just over my years, when I've compared them with the rotator cuff repairs that did not, they did significantly better over the course of their care, just kind of getting that pain trigger down early on. And so I'm not saying that everybody needs to do that, but I think it is really helpful to think about, hey, if you got that post-op patient that you're struggling to get range of motion, I can go ahead and tell you, cranking into it's not going to be the answer there. So how do you get that pain train down? And maybe it is trying to get them with the TENS for a day, get that pain trigger down, and you can actually be able to progress. So I think it needs to be in the toolkit of things that we're aware of and we're not just throwing out. So That said, I mean, either you two guys, you kind of went into them, but can you think of some specific examples where you have seen a modality to be effective in clinic?
I mean, I like you got that patient that comes in and they're like hunched over, they can't stand up straight because their back is hurting so much. They can't lay down flat on their back, they can't lay on their stomach. Like you're like, what the heck do I do with this person? That's the person that I'll slap some e-stim on, some IFC, and then just gradually start to work into some motion, after a little bit. Like first of all, they're just chilling with it on, calming stuff down. And then once they're feeling a little bit better, I'm keeping it on there, and I'm like, all right, let's see if we can just start to prop you up more towards neutral and start to work into some more normal movement patterns with the stem on there. That's a common one that I'll use. Another one would be like an acute like cervical radiculopathy that I can't get down with traction. I can't get down with like manual stuff. Sometimes I'll either stem it, or I'll even do some like more rigid taping and kind of tape their shoulder elevated, and just have them kind of hang out there to take some like load off of the nervous system there.
Yeah, good examples.
Yeah, I think the taping one is one I definitely use for a hot ridic as well. I'll sometimes use that if there's a lot of knee pain, as to do some either McConnell or KT taping. And to be honest, some of that's driven by the patient as well, patient beliefs. Uh, if they have had an intervention, something like that in the past, have seen, oh, the KT tape that the pros use, oh, that was cool. Would that help? Hey, it might. You want to try it out? Let's see how it feels. I'm going to often go with patient beliefs over maybe a specific intervention, probably every time.
Yeah, good point. Awesome. Well, good stuff, guys. I think some good clinical applications there in terms of modalities, and hopefully can eliminate some modality shaming to some degree. While still, the point is, this is not your end all be all, right? Like, by no means do we want to be getting people dependent on modalities. The goal is people moving better are going to feel better, and they're going to keep moving, get stronger, and be able to get out of our clinic. And I think that's what we all want to see. So, appreciate the discussion, and until next time.